Good morning, everyone, and thank you for coming today. I will be talking about workload metrics for academic pursuits in pathology. In preparation for this talk, last night Mike J. forwarded to me a right off the press article that just came out, written by the members of the Association of Pathology Chair, summarizing their survey on workload among academic pathologists. And surprise, surprise, it was all over the map, and they conclude that we need standardization. So this is what I do. I'm obsessed with standardization, as some of you have noticed. But today I will be focusing on the academic workload metrics, not the clinical workload metrics. For the past 20 years or so, I have been studying complex systems, and I focused on several things. One of them was better positioning academic pathologists for success. And therefore, obviously, academic workload metrics becomes a central portion of my work. I will take this opportunity to share with you exercises conducted by the two teams of pathologists I led back in Toronto, and share with you some of the successes and difficulties they ran into. This is not an easy topic. It is very complex. And what I will try to do today is to break it down to its simpler components. I will ask questions as to why measure, what to measure, and how to measure it. Hopefully, we will recognize the need for uniform academic productivity measuring tools. I'm not pitching in for any solution, and I want to say up front that I'm not suggesting any solution. This is too complex to resolve in one presentation. I'm going to ask some bold questions here, and my objective here is hopefully you walk out of the room with more questions in your head than when you walked in. That is what defines successful grand rounds. In my years of pathology, I could safely say that no other topic stimulates the same reaction among pathologists like when we talk about workload metrics. This is a very sensitive point, and people take it with great sensitivity, and sensitivity never stopped us from tackling difficult topics. So I'm just going to take a risk today and try to tackle some of the sensitive issues around workload and workload metrics. Why is it so difficult for us to talk about them? For a variety of obvious reasons. One of them, in my mind, is that workload metrics sounds like a self-explanatory topic. But when I start talking with my colleagues and administrators and carefully listen to what they are saying, I realize that workload metrics mean different things for different people, depending on the angle and the optics they are using. I just want to start by saying that, of course, I'm an anatomic pathologist, so my discussion has a huge anatomic pathology bias, but that doesn't mean that it cannot be applied to the clinical pathology faculty. And I am going to talk more about the clinical scholar track that most of us have. But again, I can say that we can extrapolate some of the concepts or some of the questions and apply them to the pure researchers in our big department. Like any grand rounds, I would like to start by presenting a case. My case today is Mrs. Jones. Mrs. Jones came to us from the community for continuing care, and we just reviewed her slides. She was a pleasant 85-year-old female with severe COPD, ongoing weight loss, moderate left shoulder pain, for 2 to 3 months, and she was investigated for that. But she also, in the process, reported increasing vaginal bleeding over the past few months. The CT showed large pelvic mass with probable lymph nodes. She did an MRI, which showed possible bone metastases in C6, C7, T1. Pelvic exam revealed abnormal cervix, and of course this is the easiest thing they went after, and they biopsied her cervix. I want to say up front that out of honesty, I don't know how much of that history was revealed to the outside pathologist who looked at her case. The pathologist outside, he received cervical biopsy of a postmenopausal woman with bleeding. And this is what the biopsy looked like. For the anatomic pathologist in the audience, you can see cervical tissue, ectocervical epithelium, and you have clusters of malignant cells infiltrating the stroma. Many of you now have already noticed that although we have a high-grade cancer in the stroma, the surface epithelium of the cervix does not seem to participate in the dysplastic or neoplastic process. It looks rather normal and reactive. A high-power magnification of this field, you can see that we have nests of malignant cells. Again, as we work through our algorithm in GYN pathology, many of you are asking yourselves now, is it squamous or is it adeno? I don't know, because some of it looks probably like adeno, some of it has pink cytoplasm, so it looks like squamous. Whatever it is a very poorly differentiated malignant neoplasm. Where does the pathologist go from here? Immunostains, of course, because immunostains seem to be the answer to every question on the planet. So they did PAX8. Obviously, they thought of a possibility of a non-GYN metastasis. It was positive, indicating that it is Mullerian. CK56, which is a marker for squamous epithelium, showed scattered positive cells. What does that mean? CK7, which is commonly seen in, or is a marker of adeno, glandular differentiation, was uniformly positive, and ER was negative. Where do they go next? Of course, the answer is always in P16, so they did P16, and P16 is uniformly positive. Cytoplasm and nuclei, strong diffuse, and therefore their diagnosis was cervical biopsy with invasive, poorly differentiated squamous cell carcinoma. This is how we received the case. I was sitting at the microscope with one of the residents looking at it, poorly differentiated squamous cell carcinoma, next case, and I said, wait a second here. The only reason this was called squamous cell carcinoma because it had malignant cells, and it was P16 positive, which is a marker for, or a surrogate marker for HPV. But we completely forgot that this is an 85-year-old female. 85, for God's sake, you are going to give us squamous cell, HPV, squamous cell carcinoma to an 85-year-old. And she already reported increased vaginal bleeding. There is no evidence of any dysplasia in the squamous epithelium. PAX PAX8 positivity is more common in endometrial than in squamous. And frankly, the CK57, which is a marker of squamous epithelium, was just focally positive. So why are we calling this squamous cell carcinoma? Wait a second. Back in Toronto, this group of gynecologic pathologists did a very good study. They studied a lot of cases to see if poorly differentiated or undifferentiated endometrial cancer can be P16 positive. And sure enough, about half of the cases were P16 positive, and therefore P16 positive should not stop us from calling poorly differentiated or undifferentiated endometrial cancer. And therefore, considering the history, considering the context, considering the immunostains, the strong PAX8 positivity, the focal CK5 6 positivity. I am going to call this undifferentiated carcinoma, and I favor endometrial, not cervical origin. I spoke to the gynecologic oncologist whether they were interested in pursuing molecular testing for HPV. They said, no. This patient had endometrial cancer written all over her. I am convinced that this is endometrial cancer. This is going for palliative therapy. Let it just sit there. What has just happened here? This is not simply a case where an academic pathologist changed the diagnosis of a community pathologist. This is not what this is all about. This is something that happens every day in every academic institution, where the academic pathologist receives a very decent diagnosis from the community based on the conventional wisdom out there, and they build on it based on their own discovery and their own knowledge, or the knowledge of their colleagues in the academic community, and hopefully they can deliver better health care and better service to our patient. So for now, I'm going to park Mrs. Jones for a few minutes, and I will come back to her later. But first, I want to give you some insight into where I'm coming from when I talk about workload metrics. I'm going to review 4 very basic principles where the employer deals with the employee. Of course, there are so many models, and there are many layers of sophistication, but I'm going to pick up the 4 common ones in a very, very simplistic way. There is a relationship called per-piece relationship. The per-piece relationship is simply a productivity-based model where the employer produces widgets, and the more widgets the employer produces, the more compensation they get. So there is a reasonable market value in producing a widget, and the employer agrees to work at that rate, and the more widgets they produce, the more payment they get from their employer. We see that typically in labor work. The other model is called contract model, and this is a service-based model, obviously. And the service-based model is about agreeing on a fair market value to produce certain services by the employees, and the employer is willing to pay for these services a certain amount. We see that a lot among professionals, like professionals in this room. Inherent in this model, however, we need to notice that if an employee agrees to conduct certain services for a certain amount of compensation, then if I struggle with these services because of lack of experience, because of lack of training, because of simply adopting unhealthy or inefficient work habits, my payment does not change. I still get the same amount of payment. So you talk to one of these professionals, they say, I'm tired, I'm overwhelmed, this is too much work. I said, and I'm not paid enough for this. But wait a second. Why are you tired, and why are you spending that much effort? Is it because the amount of work increased, or is it because of the habits that you adopted performing your service? Conversely, if the business is slow and there isn't enough work for this person, the person will still get the same payment. The hourly rate model is an effort-based model. And this is a model that enables the parties involved to factor in some of the operator-specific factors. For example, if the person is prestigious, if the person is senior, if the person is very experienced, they get higher hourly rate. Sometimes we offer high hourly rate simply for a person simply to prevent the competition from hiring them. And we can factor in some of the variables related to the task. If the task is more complex, the hourly rate will be higher. We are all familiar with the hourly rate when we deal with our accountant or our lawyers. The stipend model is a task-specific, task-oriented model, and we see that with surgeons or general practitioners covering emergency room over the weekend. You come, you produce the task, you get paid, and that's the end of that. So obviously these are very simplistic ways of looking at the relationship, and as I said, there are many layers of complexity, but I want to point out that each of these models is oriented differently. And the reason I'm talking about this today is because when I talk to professionals who are hired to produce services, and we start talking about workload metrics, and I see that they are struggling with the concept, I think this is part of the reason. Part of the reason is that they say, wait a second, we are contracted, we are in a service contract. Why are you pulling workload metrics from a per piece model and applying to us? That shouldn't be the case. I'm here to do service, not to produce widgets. I understand that, and I want to say this up front, that this is the reality of the work in which we live. I think an employer has the right to measure our productivity and has the right to measure where we are going for planning, for faculty planning, for policy planning. And we as professionals, we hold ourselves accountable for our work and for our time as well. So I don't see anything wrong with measuring our workload, because this is the one way that we can not only validate ourselves, but also protect ourselves from being overworked or burned out. So I want you to meet my pathologist here. This is a pathologist who is hired on a typical clinical scholar track. And in every contract, there is a proportion of the clinical service and the academic service. So for this example and for the discussion today, let us say that this pathologist is hired on a 75-25 split. We are all familiar with this model. But if I ask anyone, what does 75 mean? Oh, this is obviously clear. It is, I actually don't know. What is 75? What does it stand for? Is it 75 of what? So the logic would say it is 75% of your time. So the proportion is a split of time. You will spend 75% of your time on service and 25% on academics. That makes sense. But the only time this would make sense is if this is also linked to the workload. Because if you put me on a workload that is more than 75% of the community pathologist, and say I'm going to produce this in 75% of my time, this is not going to add up. So 75%, it becomes only a theoretical concept. And as a matter of fact, back in Toronto, in one of the hospitals, we agreed that this is, forget about it. There's no such a thing as 75-25. I gave the same talk in Mayo Clinic last month, and they just opened their mouth. Their jaws dropped like, what are you talking about? What is 75? There's no such a thing as 75. So again, it becomes theoretical, but maybe I am a dreamer. I would like to keep this concept, but I would like to keep the 75% of time, but I will link it to 75% of the workload. Or is it 75% of your effort? And that is a very complex discussion, because our effort is determined by our own, by our personality, our habits, our efficiency, our seniority. That's a very, very difficult discussion. Or is it 75% of our output? What is the difference between output and workload? I think there is a difference. In the clinical field here, I think what comes in goes out. If you give me 100 specimens, which is my workload, I'm going to produce 100 reports. Obviously, this matches. But for the academic piece here, and this is what I'm talking about today, the output is maybe different from the load. How much are you going to allow me to produce academics, and how are you going to measure my output? And this is what my presentation today is about. So when we talk about linking time with load, there are many models for that. My colleagues in anatomic pathology are familiar with our 10 weeks load. So in my mind, I would get the community pathologist workload, which is this here, the 100%, and I will say you are going to take the same workload for 7.5 weeks. That is your 75%. In other words, 2.5 weeks, you will be completely off the schedule. So when we allocate time, I would like for time for academics to be, I define it, at least with my colleagues here, is that the time when your name does not appear on the schedule. Sometimes this is not possible, so let us do this one here, in which I look at the 100% workload of the community pathologist, and then I will get 75% of that every week. And then I would have to work on my own schedule to integrate the 25% academic every week and every day. So obviously, depending on the department, depending on staffing, depending on the specialty, depending on the culture, depending on so many factors, we can choose any of these models, or maybe a hybrid or any other model. But I would like to completely separate the allocation of time from the workload so that it will make sense. So while we are talking about workload and the split among pathologists, and there are so many metrics, I will review some of the metrics available to you now. Who is talking about metrics for the organization? Who is talking about how efficient the organization is? And this is my little elephant in the room here. Because in my ideal world, there should be certain metrics that we apply to an organization and then come up with an efficiency index for an organization. Depending on how the efficiency is in the organization, the workload, clinical and academic, could go up or could go down as much as the efficiency index of the organization is. And this makes sense, of course, in all of our heads. We all have seen departments that are more efficient than ours or less efficient than ours. And we know that if you work, for example, in one of the most efficient places I've seen was Alina Abbott Hospital, it's a very efficient system. They bring the slides to you at your desk. You want to show the slide to your colleague, you put the slide in a certain place in your office, and there's a guy who comes like almost on a roller blades and takes the slide and shows them to. So like that, it's like very efficient system. The outcome of that, obviously, is that the workload, the expectation becomes higher. We all know that. The more efficient the system, the more productive people are. But I would like this to be quantitative. I would like this to be measured. So I can come back to the pathologist and say, this is how efficient we are, and this is how we are expected to produce. Again, today I'm not talking about clinical workload, I'm talking about academic productivity. So I'm talking about enablers rather than efficient. How enabler is the organization to get me going with my academics? And those of you who know our effort in anatomic pathology and in other divisions in the department of hiring, for example, research coordinator or research assistant, it is for that very reason to increase, to provide enablers to the pathologists so they can produce their academics. Of course, if we are going to provide research associates, if we are going to provide database, if we are going to provide data analysts, then you can see that the academic expectation is going to go up. So obviously there are so many moving pieces to this topic, and no matter what you are talking about, if you are talking about compensation, if you are talking about workforce planning, internal equity in the department, accountability, no matter what you are talking about, we always come back to workload measurements. But I noticed over the years that we can get ourselves in very serious trouble, because I noticed that the philosophy used to develop certain metric applied to one situation could be very different from the philosophy needed in another situation. And to take a measuring tool that was designed for one purpose and apply it to another discussion can get us into very serious trouble. And there are many case studies for departments that has done just that one mistake. And therefore, I maintain my position that when people start to talk about workload metrics, I first take a pause. I say, what is it that we are trying to do today? Tell me your question, and I will go to my toolbox, and I will pull out the metric that applies to you. But it is not one size fits all, and I really don't like, because I know how wrong it is to apply one tool from one question to answer a different question. Don't even get me started on the internal equity in the department. This is a topic of a very different discussion, because internal equity is dependent on so many complex factors that probably are beyond this discussion. So before I leave this piece here and start focusing on this piece, the clinical workload, there are so many metrics. We are all familiar with these metrics. In this country, work RVUs obviously are very popular. They were developed by CMS, and they were developed mostly for compensation. In the UK, if you go to the Royal College of Pathology website, they have a very robust system for staffing their departments. In Canada, I was part of a nationwide project was championed by our colleagues in the University of Calgary to develop metrics for staffing of departments. It's called L4E, or level 4 equivalent. A group of pathologists in Toronto realized that none of these metrics is helpful in equal distribution of workload, and they came up with this very complex COPATH-based informatics tool that can measure workloads within the department, and to make sure that everybody is doing the same work, irrespective of your specialty or irrespective of anything you do. And this is exactly the example I'm talking about, that when we talk about RVUs, this model was developed for compensation. So sometimes we take that and apply it for staffing or apply it for equal workload distribution within the department, and I don't think this is right. We cannot compare RVUs within the same department between people to see who is working more than who. This is obviously, it doesn't work this way. Again, going back to my earlier questions, what is it, the 75%? 75% of time. As I said, I measure this by the days a person's name appears on the schedule. Is it load? We measure the number of cases. Is it effort? There is a recent publication about stress metrics and how to measure effort of pathologists and how to measure the output of a pathologist clinically. I think the RVU is the tool for that, if we are talking about compensation or maybe staffing. But this is what I want to focus on now. I couldn't get this far without analyzing this piece first. The portion of our time that we are spending on academic work. Do we have any accountability tool here? How can we hold ourselves accountable for our academic work? And more importantly, actually, is how are we going to use this data? Are we going to use this data for the individuals, or are we going to use this data for the whole department and the whole system? I will come back to that. Let us go back to anatomic pathologists and what they do. This is what we do every day. We receive a specimen, we run some analysis on it, we collect data, and then we put the data in a professional opinion in a report, and the report is basically the clinically actionable information that we release back in the system to serve this patient. This is what we do every day. We do this maybe tens of times, hundreds of times every day. We release clinically actionable information for the patient. This is what we do. This is what the community pathologists do. This is what the pathologists in the Middle East do. Every pathologist does this. This is not unique to us academic pathologists. But Mrs. Jones' case has shown us a separate layer of knowledge, that academic pathologists had and were able to apply to the care of Mrs. Jones. What is knowledge? This is a very philosophical discussion, and I don't want to get too deep into that, even though this is something subject of great interest to me. Plato defines knowledge as justified true belief. In other words, you can say that this is a fact if you believe in the statement, and if the statement is true, and if you are justified in believing that the statement is true. So, built in the knowledge, a very critical component of knowledge is evidence. This is evidence. I have to have evidence in order to say I have knowledge. In other words, if I create the evidence, if I disseminate the evidence, then I do have the knowledge. And this is exactly what these guys did. They collected 28 cases of undifferentiated endometrial cancer, 20 cases of high-grade endometrioid carcinoma, 50 cases of cervical cancer, and they run a very large battery of immunostains, and they found out that 50% of cases of endometrial cancer were P16 positive. They also found out that about 1/3 is CK7 positive. So CK7 positivity doesn't exclude, and P16 positivity doesn't exclude endometrial cancer. And therefore, these guys could actually say that I know that P16 positivity in undifferentiated carcinoma of the uterus does not exclude endometrial origin. I know that. That is knowledge that I created, and that is knowledge that I disseminated in my lecture today. So I believe it is true. It is true because I have the evidence for it, and I'm justified in my belief because I was part of that study. That is knowledge, and that is what makes an academic pathologist. So I can go back to my friend here and say that this person is spending 75% of his or her time creating clinically actionable information, and 25% creating and disseminating knowledge. When I put this side to side with his colleague from the community, who is equally respected and equally valued, I'm not saying anyone is better than the next, but all I'm saying is that I am creating and disseminating knowledge as an academic pathologist in 25% of my time, and that is what I am accountable for, and this is what we need to measure. So going back to this model again, we receive the specimen, we run the analytics, we collect the data, and we release clinically actionable information in our report. That is what we do. This is what the community pathologist does. But we, academic pathologists, create this whole new layer of knowledge. There are so many activities involved in creating and disseminating knowledge. But if you break it down, and I will break it down to you now, hundreds and hundreds of activities, and it trickles down all to the way I disseminate the knowledge in terms of a lecture or create the knowledge in the term of publication. So I want to leave this slide before you for maybe 2 more seconds to see these 3 chips or these 3 coins that can be measured, that can be quantitated, and they do represent what we academic pathologists do every day. A community pathologist, equally respected, does this part here. They release reports. And you can count their reports. You can count their widgets. But I think everybody in this room here is commissioned to create knowledge and to publish, and we can count your papers. And you are commissioned to disseminate the knowledge, and we can count your lectures. So we come to lectures, reports, and publications. They become the 3 chips or the 3 coins or the 3 currencies that we are talking about today. We badly need objective metrics for our academic productivity. I've been saying this for 20 years because academic pathologists struggle position positioning themselves in complex systems. So what I did was, out of craziness, I asked several members of the department with very diverse profile, clinicians, clinician scientists, clinician educators, clinician teachers, PhDs, researchers. I got a big collection of people. Some of them liked me, some of them didn't like me, but I got them all together in a room and I said, could you please collate a list of the activity that an academic pathologist is performing every day. I did this exercise in one hospital, and when it kicked in, I took it to the other hospital, and I saw how the two teams developed their list. It was a very interesting exercise because, as you will see from my presentation, academic productivity is very institution dependent. It is very cultural. And what is academically valuable to us here today at the University of Minnesota might be slightly or very different from what is significant for members of pathology at the University of Baltimore, for example, or Maryland. So they came up with 3 buckets, and I think across the board, all academic pathologists will agree on 3 buckets. A bucket for knowledge creation, research, a bucket for knowledge dissemination or education, and a bucket for creative professional activity. Creative professional activity is defined as the non-research, non-educational activities that influence the practice of your colleagues in your field. And I will give you some examples of that. And this is something that we do every day, and it is not captured. We don't capture it because it doesn't translate into a paper, it doesn't translate into a lecture. So if you see my name on a CAP checklist for endometrial cancer or ovarian cancer, this influences practice of pathology all over the world. But does that count in my academic productivity? I think it should. So these 3 buckets are universal, and I think you would agree with them, and it was agreed by members of both departments. And then they started putting activities in the bucket, and this is where the culture kicks in. And you can see, it was a huge list. I just kind of abstracted the top part of that list for the slide here, but all of us, we can talk for hours about academic activity that we perform in research, conducting experimental, clinical, translational, educational research, whether I run a lab, I supervise a lab, I do this, I do that, peer review activities, publications, manuscripts. Some of the manuscripts are accepted, some are not accepted. And tissue bank, Bionet, and other research activity. Similarly, in the educational bucket, they collated the famous list of undergrad, postgrad, graduate, CME, teaching other healthcare professionals, talk about critical thinking. So all of these educational activities, and again, this is very cultural and it is very institution-based. Creative professional activity, as I mentioned, professional innovation, developing new antibody, molecular assay. Our colleagues in cytogenetics and molecular pathology are developing new assays every day. Is this clinical service? Is this academic? Is this research? Is this teaching? It is creative professional activity. And I think we need to get credit for them. A very, very long list, and this is, again, as I said, just a summary of some of these points. So the next step was to assign value to these activities. And how are we going to assign value? Based on what? Of course, the value of the activity depends on the time a person spends in a particular activity. But it is not just that. It had to be linked to the university promotion manual, because I personally believe, and I think many of us would agree, that academic activities that would help the individual in their promotion from assistant to associate, from associate to full professor, should be weighed heavier than activities that something I like to do, a topic I like to talk about and whatever, but it's not taking me anywhere. Yes, it will be valuable, but it will not be as valuable if we focus on first authorship papers. This is important because in our institution, this is the driver for our promotion. So the value could be assigned taking into account the time spent and how heavy the activity is for our promotion. We know that our pathologists in a typical day, they can do multiple activities, and that is where that graph I showed you, where you can do 75% of the work every day and then manage to keep an hour or two every day for looking at research slides or writing a manuscript. And in the last faculty meeting, I asked my colleagues, would it be okay to close your door, lock your door, so that you will not be interrupted because you are working on a manuscript? That question came from a previous experience in one of the hospitals in Toronto. One hospital pathologist closed their doors and did not think twice about it. In another hospital, I asked pathologists to manage their time and close their doors and put a don't disturb sign. One of the pathologists was very offended. She came to me and she said, "This is very rude. This is rude. You can't put that on your door." I said, "Well, I do it all the time. When I don't want to be interrupted. I'm working on a manuscript and I don't want to be interrupted." So we had a nice discussion, and obviously we didn't come to a conclusion. But the point is, we do everything every day. So some of us, and I know some of the colleagues, come to me and say, "Tomorrow I have to work on a manuscript. I'm not coming." I said, "Oh, please don't come. Stay home, work on your manuscript." And then, so that person could manage their time on daily basis. That's fine. My colleague here told me, "I don't want any service in January. I'm working on my grant." Absolutely. So that person works in months. Some of us work in hour. I work in a minute increment. So serious. I mean, someone walks out of my office, I do something, and the next person comes and I put a smile back. So this is how it works. So we know that. So this is part of who we are. We should manage our time in whatever way that gets us somewhere. Now the next step is, what is going to be the unit? What is going to be the unit against which we can measure all of our activities? We can talk about that, obviously, but eventually we will have to agree on the basic unit. Interestingly, the two teams independently agreed that the smallest unit, academic unit, is a lecture with minimum preparation. A lecture with minimum preparation is defined as a lecture that you have given to residents or medical students a couple of times before, and you are pulling it out from your file and delivering it again. This is probably the smallest portion of, and this would be the currency against which we are going to weigh things. Again, this is a very cultural thing. Maybe the culture in another department will say, no, this is not the smallest. The smallest unit is a case report on whatever. So going back to the calculation for our friend here, who's 75% clinical, 25% academic, that 25% translates to 13 weeks in a year. If that person takes 2 to 3 weeks vacation and goes to USCAP and another meeting, or takes a course for 2 weeks, then we are left with 8 weeks. Is this fair? Yes, it is fair. Because I can't take the vacation from the clinical service, because this is how compensation is based on. So we are compensated based on here, so I think it is fair to take our vacation from here. As a result of that, however, we are left with, this guy is left with 8 weeks for academic productivity. So how many academic units is expected in 8 weeks? Going back to my model of the lecture I gave to residents twice before. So I'm going to give this lecture today. If I'm not doing anything but giving this lecture, It means that I need to come to my office, read the lecture, go over it maybe a couple of times, add a couple of slides, delete a couple of slides, put a new paper and polish it, and then walk to the residence and deliver the lecture for an hour and hang around a little bit with the students, answer some questions, go back to my office, modify it again, write few exam questions for that lecture. So that's a half a day. So if I'm not doing anything but that lecture, it took half of my day, which means that I can deliver 2 of them in a day, or I can deliver 10 of them in a week. So they agreed that for this person here to be accountable for the 25% of their time, they have to produce 80 units. So 80 units was the bar for this pathologist. Of course, the bar goes up or down depending on the portion of academic time that is available to them. So going back to the research activity, here's the list. They started to allocate points, taking into account that this is the basic unit. And this was the interesting discussion. You can imagine that everyone wanted to add more units to the kind of activity they do. And that was a healthy discussion. Nothing is wrong with that. At the end of the day, we will agree, and at the end of the day, they agreed, and everyone who wanted to add, like I'm organizing a course here, and I need 20 units, then that person has to make a case as to why this activity equals 20 of your lectures. So going back to residence training, residence teaching, because you can see here the person is allocated 2 units for residence teaching per week. Where did that come from? It came from some calculations. If you are spending an hour and a half or 2 hours with a resident every day, then at the end of the week you probably spend 8 hours a week. 8 hours a week teaching residents, that comes down to 1 day. And as we said, a 1 day would equal to 2 units. So every week you spend with residents will give you 2 units for 2 academic units. Research, again, came up with a nice list and listed the manuscripts. And what I liked about this is how you can see how basic science papers had a lot more units than case reports and clinical series for the obvious reasons. And David Wang is a very excellent MD PhD lung pathologist back in Toronto, came up with what he called impact factor multiplier. He said that the ideal journal for all anatomic pathologists is the American Journal of Surgical Pathology with an impact 4.2. Then when you publish a paper, we should divide the impact factor of your journal by 4 and calculate the units. So, for example, this person here is a primary author on a case report. A primary author in a case report gets 5 units, but you multiply the 5 unit by the impact factor of that journal divided by 4, then you only get 3.6 units. Very clever. Because the other person, who is only a collaborator on a basic science paper published in Nature, wait a second. So here, if you are a collaborator on a basic science paper, you get 6 units, and with an impact factor of 38.1 divided by 4, imagine what happens, 57 units. Is that fair? Absolutely fair. So this is how it works. At least in that department, creative professional activity, again, meetings, working on antibodies, guidelines, publishing protocols. You probably see my name on the Canadian Initiative for Intestinal Polyp reporting. It's a guideline for all Canadian pathologists. It was not a publication, it was not a lecture, but it is a creative professional activity. And then we had an actual calculator here where you have educational activity here, research activity here, and creative professional activity here. And this calculation for this doctor, for example, Dr. Smith, he gave 5 lectures, he gets 5 units, He gave 2 lectures with substantial preparation. He gets 8 units, and so forth, so forth. At the end, he scored 85, which crossed the bar of 80. The purpose why I'm showing this calculator here, because really, when you look at these activities, you don't think much of them. I mean, a pathologist, an assistant professor who published a couple of case reports, gave few lectures here, attended some meetings, and did these activities, they don't feel that they did enough academic work. It's not, is it, did I do enough? And I see it with the mentorship meeting. Pathologists, because we are very hard on ourselves, I don't think I've done enough. Well, you don't think you have done enough because it wasn't quantitative. But if you put it in a calculator, and if we agreed that you need to meet a certain bar, you may actually come out much better than you thought you would. So the exercise, this exercise involves these steps, and this is not new. This has been done in so many universities across the country. Some of our colleagues talk about University of Iowa, and I know in Hopkins, they have these things. You need to start with the list of academic activity. You need to decide on a basic, what is the basic unit, and then you start assigning relative unit value. You need to develop a reasonable calculation model, whether it is 8 weeks or 10 weeks. We need calculation and validation, and this stuff will only be meaningful if it is validated. In other words, it is done over a few years, if it is done in more than one institution, and it is tweaked. And then we need to use the data, and this is where actually I think the money is. How are we going to use the data? I think this could be very powerful, because the culture of our department here is that it focuses on the mentorship and mentorship committee. So I think, and Jim, you can comment on that, whether such a tool could be helpful to members of the mentorship committee for designing the ICDP and discussing achievements with individual pathologists. Depending on an institution, and this is a very touchy question, can we trade points? In other words, if I didn't produce enough academics, are you going to increase my workload? Convert academics into clinical workload, or vice versa. In one hospital, interesting about the culture, in one hospital they thought that this was a totally acceptable concept, because if someone needs more academic time this year for promotion, I can do more work, but reduce my academic output so that my colleague can pass. In another hospital, they said, "Oh, this is crazy. You cannot do that." Why? Because if I don't produce academic unit this year, and you punish me by increasing my workload, then this means that next year it will be harder for me to meet the bar, and it will continue. It's almost like credit card debt. It will be very difficult for me to get out of the hole. I said, "Do you really think so?" They said, "Yes, we do think so." So that hospital did not do it, and the other hospital accepted it. Guess what happened? What I predicted would happen. These guys who accepted it, they knew that this was going to happen to them. So they said, "I better not allow myself." It's just like you not allowing your credit card to accumulate debt, because you know after a certain time you will not get out of it. So they said, no, you're not going to do this. I know where you are going with this, and I'm not going to give you that much. From day one, they said, "Okay, 40 units is what you want from me. I'm going to do this, and that. If I do that, would you get off my back?" I said, "I get off your back," and that was the deal. And they did it. They did it. Even though the risk is real, the risk did not happen. Nobody fell in a credit debt with their academic unit, because they are smart. Everybody in this room is very smart. If you know that this is what is going to happen, you are going to cleverly pick the things that you are capable, things that investment that will get you more units, and things that will keep your academic in check. Of course, if this if one person is not meeting that bar consistently, then maybe we need to change the job description for that person. I mean, I cannot get the 80 units, so I'm willing to go 80-20 rather than 75-25. So at the end, I just want to leave this with you, that we are in the business of knowledge. That is what academic pathologists do. And as we count reports, we need to count publications and lectures in an intelligent way, so we can hold ourselves as professionals accountable for our work. Publications and lectures are our simplest currency for knowledge creation and knowledge dissemination activity. We need to validate our metrics, we need to develop metrics and validate them for our academic pursuits. And as I always say, metrics are not the discussion, metrics are the beginning of the discussion. The real discussion is how we can develop the career trajectory for each one of us so that they become successful if they know how to spend their time and what to get. And I didn't even touch on the issue of burnout or lifestyle. That's a discussion of a whole different presentation. But I must say, it hurts me. It hurts me when I see pathologists focusing so much, because that's what we do. And I always say pathologists are notorious for this, because we never want to compromise quality. I will do whatever it takes to get the highest quality possible, even if I stay late, even if I work weekend, even if I neglect my family, I neglect my loved ones, even if I run in health problems. We had in Toronto, we had a fantastic hematopathologist that we hired from New York. She was in her 70s. She was very accomplished, world-renowned hematopathologist, and she was living by herself in downtown Toronto. On a Christmas vacation, on the Christmas holiday season, the hospital was empty, and she would come. She was carrying the entire department by herself. While crossing the road early in the morning, it was dark, she was hit. She fractured her hip. Poor woman, fractured her hip. She went to the hospital. Next day, she was in the hospital, in the office. She was working. She was coming on a wheelchair, and she was coming. I said, "What's wrong with you?" She said, "I can't." This is people. This is real people. She came with a fractured hip because she knew she had to deliver this. This should never happen. This is quality of life, and I'm not going to even talk about this today. Thank you very much.